Hello and welcome to my presentation. Today we'll be discussing an article which was published in 2011. It's a study from Syria which looks into smoking effect on ischemic heart disease in young patients. So starting with the background of the myocardial infarction under the age of 45 years accounts for approximately 10% of all infarctions in the United States. Smoking can trigger myocardial infarction in individuals with minimal atherosclerosis or even with normal coronary arteries, especially among the young. And although smoking is a well-established risk factor for early atherosclerosis and plaque instability, it has not been comprehensively evaluated using a population-based study. So that's exactly the kind of study that we'll be looking into today. The objective of my study is to evaluate the effect of tobacco smoking on the risk of non-fatal acute myocardial infarction in young adults, which is, they define it as less than the age of 45 years, and to also examine whether there is a modification of this effect by gender. The type of my study is a case control study, and the authors are seeking to generalize their findings on the general population of Syria between the ages of 18 and 45. So coming to the patients and methods part of the study. So our study had a sample size of 329 cases and 778 controls. Of the 329 cases, 42 were women and 287 were men, and of the controls, 486 were women and 292 were men. And over here, we can appreciate a disproportion of women to men. So we can see that the cases had much less women than the men, and the controls had much more women than the men. The authors did not perform any power or sample size calculations, and the recruitment strategies that they employed were they took participants aged less than 46 years, and these participants were recruited between the years 2008 and 2010. And these participants had no evidence of ischemic heart disease according to self-reported previous medical diagnoses and electrocardiography. So moving on to the inclusion criteria. The cases were Aleppo adults aged from 18 to 45 years, and they were consecutively admitted with first diagnosis of acute myocardial infarction to the Department of Cardiology of the two hospitals providing acute coronary care in Aleppo, and who survived at least 4 days after the acute event. So they were admitted to the hospital, and they were given about 4 days for them to stabilize, and then they were interviewed. The diagnosis was established according to the criteria defined by the European Society of Cardiology and the American College of Cardiology: acute myocardial infarction with and without ST segment elevation. If you look at the exclusion criteria, it was primarily composed of patients who did not meet the age requirement or the diagnosis of the criteria, and it was patients who were unable to participate or died before completing the interview or had an incomplete interview. So these people were excluded from the study. The controls were identified as a part of a health and nutrition survey of the adult population of Aleppo, which were representative of the catchment area of the hospitals where the cases were recruited. Random digit dialing was used to select households, followed by simple random sampling to select one participant within each household. Demographic variables were comparable between cases and controls. Moving on to the statistical analysis that was carried out in the study. So the authors used a chi-square test to evaluate the association between the two categorical variables. A t-test was also used to compare two or more independent samples according to variables distribution, and to estimate the magnitude of association between smoking and myocardial infarction. Adjusted odds ratio with 95% confidence interval were calculated using unconditional logistic regression. Association between acute myocardial infarction and different covariables were evaluated in regression model to see what was the relation between smoking and other variables. So now we come to the results part of this study. So overall, in this population-based case control study, a strong positive association was observed between smoking and acute myocardial infarction in young adults, and the effect was not modified by gender. Additionally, a clear dose effect response was present, the odds favoring myocardial infarction reaching an 8-fold increase for those who smoked more than 25 cigarettes per day. As we can see over here, the prevalence of current smoking was 80% in male cases and 53% in male controls, and 59.5% in female cases as compared to 35.8% of the controls. So that is a significant difference in that way. In addition to this, myocardial risk increased with increasing daily number of cigarettes smoked, as I mentioned previously. The risk of an acute myocardial infarction doubled in smokers of 1 to 15 cigarettes a day, and smokers of 16 to 25 cigarettes had a 3 times higher risk, and the odds for heavier smokers were 8 times higher compared to never smokers, adjusting for age, gender, and education, as I mentioned earlier. So, like in simple terms, people who were heavy smokers had an 8-fold increase in the risk of getting a myocardial infarction. The results were multivariate as the researchers controlled for confounders by including various models. These included adjusting for gender, then another model included adjusting for gender, age, and education, and so on and so forth. So coming to the conclusion of this study supports that tobacco smoking is an important independent risk factor for acute myocardial infarction in young adults, with a similar effect for both genders. And I agree with the conclusion of this study as it is consistent with the current data available that smoking is indeed a risk factor for heart disease. That is proven by many studies, one of which I have linked right here. In addition to that study, there were other studies done as well on the similar subject. For example, an Italian study presented an adjusted odds ratio 32.8 for young heavy smokers for having ischemic heart disease. And in the Framingham Heart Study, the risk of myocardial infarction also increased with the daily number of cigarettes smoked. An increase of 10 cigarettes per day increased the risk of cardiovascular disease by 18% in men and 31% in women of all ages. So now we will look at the limitations and biases that are present in this study. So as we know with all case report studies, this study is prone to recall bias, which basically means that the people who had the myocardial infarction might overemphasize their disease and link it with smoking. Other limitations include the fact that the authors did not take into consideration passive smoking, and therefore overall risk they might have underestimated. In addition to this, sample size contains disproportionately small number of women, and control population includes a large number of women, as I mentioned earlier on in the presentation. Overall, the findings of the study are applicable to the general population. Case control design was a good design for this particular research question. However, depending on a different research question, a randomized control trial could also be carried out. This can be similar to the study that was carried out in diabetic patients with ischemic heart disease who were smoking and were treated with medical therapy and lifestyle modification. So this brings us to the end of the presentation. Here are my references, and thank you so much for your attention. Thank you.